Okay, welcome back, everybody. I believe that this is actually the last lecture which we have for the term, which feels very fast, but this is how these accelerated courses go. You guys should be getting a sort of like end of term course review. If you guys could take the time to fill that out, that'd be greatly appreciated. Originally, I was going to do three or four separate lectures today. However, I sort of realized that they all interconnect in really interesting and somewhat still very politically relevant ways. So I want to talk about misinformation, vaccine mandates, distribution of scarce resources, and the like. I think that all of these have become incredibly important topics post-COVID. I'm sure all of you guys have heard quite a lot about this. I'm sure most of you guys have very strong opinions about these. So we'll be getting into this. And of course, this is going to get somewhat political, but I don't know. You can't really separate policy from politics. So let's just get into it. Okay. First, I want to talk about misinformation. No matter what sort of side of the political spectrum you are on, and obviously, um, medical information has become heavily politicized within recent years. Really, in the lead up to the pandemic, you saw it, and then it started to kind of hit its zenith during the pandemic. Um, no matter what type side of the political spectrum you are on, I am sure you believe that there is a plethora of medical misinformation. This is just undeniable due to the fact that you go online, you take a look at medical information, and it seems like every other person disagrees with one of them, with each other. I think it's somewhat important to start thinking about what may contribute to misinformation. And I think that there are a couple main factors which I kind of want to highlight and which I think about a lot when I think about misinformation. The first factor which we can think about is just general incompetence. Um, I mean, people, when they're telling information, it could even be reporters, doesn't necessarily have to just be like your random uncle on Facebook. There's some level of incompetence that comes up. Sometimes people will read articles, they'll misunderstand them, they'll misquote things, they'll hear something from an unreliable source and not realize it's unreliable and report it. Uh, this leads to massive confusion, and you can see, numerous examples of this. Um, but I think one of the more important things that I kind of want to highlight, which oftentimes leads to misinformation, spread of medical misinformation, um, is the misunderstanding of the scientific establishment. Now, this isn't just related to medical misinformation and the spread of it. This is also just related to scientific misinformation in general. But if you go online and you're scrolling through Instagram or scrolling through, I don't know, like the Daily Mail or whatever, you'll constantly see these articles which post things like scientists discover, and then they put some sort of like really surprising um, discovery or supposed discovery afterwards. Usually you'll go ahead and you'll click on the link and you'll see a variety of different things. Sometimes it's just clickbait. They're heavily exaggerating the finding. But one thing that a lot of people don't understand is that these uh, these posts, they almost always highlight some sort of individual scientific study. And then they show that this individual study concluded something or concluded that something is possible. And then they represent that as fact. In general, in science, people don't rely on individual studies to determine that something is true. Um, there is a whole history of sort of odd one out studies coming out that may highlight something that seems to be true, but isn't actually true when you take a look at the grand evidence. There are some pieces of some establishments which have ulterior motives. There's a long history of that, which maybe have some sort of financial incentive to say something, and there's also to some extent um, a level of um, deceit, which sometimes occurs in individual scientific studies. Uh, these I mean, there are regulations and policies and laws to try and counteract these effects, but there's no way to possibly, get rid of them in terms of the entire scientific establishment. In general, what scientists do when they're trying to figure out what the general findings should be or what they should believe is they take a look at the entire culmination of the evidence. So they're not going to take a look at one single study. They're going to take a look at all of these different studies, which were ran by different scientists with competing interests and different from different establishments, and they'll try and figure out, okay, well, what does all of this information point to? And this just misunderstanding of how scientists in general come to conclusions uh, by looking at the aggregate data instead of looking at individual studies leads to a massive amount of misunderstanding and misinformation. Because what people will oftentimes do is they'll take a look at these individual studies, they'll see that these individual studies came to some sort of conclusion, then they'll think, okay, well, this is the scientific consensus. When in actuality, it's just a single data point that scientists are going to weigh, but it's not necessarily going to be the main determiner of what the scientific establishment is going to think. I see this a lot. My mom sends me these articles with these sort of usually they're like outrageous like diets, where, some like quack scientists will come up with some sort of conclusion or run some sort of study, sometimes with a sample size of like two people. And then post, scientist discovers this. In actuality, that's just not how the scientific establishment works, and it's not how it should work. Um, in general, people believe that there's going to be reliability, which comes from numbers and all sorts of different competing interests arguing with each other democratically and trying to prove and disprove each other. You don't just get some sort of consensus from a single study, pretty much never. Of course, there's also people who have ulterior motives. I think that there's this sort of interesting thing that happens oftentimes now when there's uh, a lot of political discussions, especially happen online, where there are some groups which have some sort of ulterior motive, oftentimes ulterior financial motives. And what you kind of see is you start to see their information spread into otherwise reliable forums. Um, and sometimes it can kind of be hard to track down exactly where this information is coming from. But sometimes you can kind of see some talking points from people who may have some sort of ulterior motives will sort of get thrown into the mix, then diluted down. Again, you don't just see this with medical misinformation. You also see this with general misinformation, especially in politics. Um, you actually see this a lot with the proliferation of sort of like white supremacist talking points, where you'll see, you'll just be looking at maybe say like a relatively like mainstream conservative forum, and then you may start to see some talking points which start to resemble some things that white supremacists have been talking about for years. And the actual explanation for what's going on here is that there'll be some people who are white supremacists who go to these more moderate forums, and then they'll start to kind of dilute their ideas down and put them in the mix. And then suddenly people start to believe these more palatable and watered down versions of like classic white supremacist talking points. Same thing happens when it comes to medical information. Okay. There's just some basic thoughts related to misinformation. I think that there are two main problems that I want to talk about as it relates to misinformation, which I find particularly interesting. Um, the first problem is definitely something that you guys have heard about and probably thought about before, which is just the ethics related to the enforcement of misinformation, where we could kind of think of this as being paternalism and censorship in order to get past misinformation. Um, the second problem, which I'll get to in a second, which I think is much more interesting, and it's something that I've been thinking about quite a bit recently, is whether or not misinformation in the medical context, especially, can impair informed consent. Okay, so a few important things that we should establish regarding the enforcement of misinformation. Um, First, in general, when we talk about the enforcement of misinformation, at least kind of coming from the context in the United States, we're mainly concerned about what the government can do to enforce misinformation. At least this is the classic sort of legal concern, and to some extent, the classic ethical concern. A lot of these legal reasons are just based upon classic liberal politics. Um, in general, we'll hold something like this. We'll say that individual publishers, which include websites, they have the right to determine what they can and can't publish. So we'll hold that, I don't know, Facebook or Twitter or whatever, uh, they can sort of determine their own policies about what is allowed to be posted on their websites and stuff like this. In general, enforcement when we think about it is whether or not the government should step in, or questions related to enforcement are about whether or not the government can step in. I think that this has been questioned, and I think possibly reasonably so in recent years. I think that as more conversations and more information is learned via websites specifically, these kind of third-party non-government ran websites, I think that there's a real question whether or not the sort of we can think about it as like the spirit of free speech or something like that can actually be is actually being enforced or is actually being upheld if we start to let these individual websites, which hold, a lot of social capital, uh, regulate what can be said quite explicitly. But I'm not going to get into that too much here. Um, Additionally, in classic liberal politics, we'll hold that it's generally fine for people to spread misinformation in some context. Now, there's obviously limits to this. You can't defame anybody, but we think that it's generally okay for people to say things that are at least false. Whether or not that's exactly what misinformation means is an interesting question. Misinformation maybe is purposefully spreading wrong content. But, maybe we can just think of misinformation as things which are verifiably or almost verifiably false. Um, the classic argument is going to be something like this. In democratic contexts, there can actually be a lot of value to allowing people to say false things. This is sort of a classic argument by John Stuart Mill. One of the readings talks about this extensively. And if we kind of just think about public debate as being something which leads to the truth, well, then allowing people to say false things in situations where arguments could be productive, uh, well, it can be productive and thus it should be allowed. That's sort of the classic belief. Um, Now, obviously, if we allow people to say false things, there seems to be some sort of basic reason as to why enforcement of misinformation may be stopping free speech. I think that there are interesting reasons to say that it's not actually really stopping free speech, or at least the type of free speech that we care about, which we should protect. Um, One of the readings which we talked about one of the readings which I assigned, the Saunders reading, he kind of takes a look at what John Stuart Mill would say regarding free speech, which is, he's a very classic liberal philosopher. And he actually shows that John Stuart Mill had a variety of different exceptions where he said that in situations, especially emergency situations, where deliberation won't occur due to freedom of speech, it may actually be completely permissible for the government to restrict free speech, and he then argues that John Stuart Mill may extend this to situations involving pandemics and stuff like this. I think that that's a pretty normal argument, pretty reasonable argument. I think that you're going to start to see this trend, right? And we're thinking about this, especially when it comes to misinformation in times of emergencies, right? This is sort of, some sort of post-COVID thoughts. Um, You start to see this trend when we take a look at ethics related to emergencies, which is that in general, when we have emergencies and situations where many, many people are at risk, we start to prioritize individual freedoms and individual liberties less and think about the collective good more. And we're going to be talking about this a little bit, but it may very well be the case that in normal situations, whatever that means, it is completely fine, or the government has some sort of obligation to not censor information that goes on. However, in emergency situations, the government can censor information in certain cases. This topic's been talked about to death. I'm not going to talk about it too much, but it's worth bringing up a little bit. The more interesting topic which I want to talk about is whether or not misinformation can impair informed consent. Okay. So we've talked about consent and consent in the medical context. It's not just about what people can do or not do. Um, Consent also has this informatus requirement. Essentially, people need to be aware of all the relevant alternatives, and they also need to be aware of what some sort of procedure or practice or medication or whatever will actually do, what the possible results are going to be, in order for them to be able to legitimately have been capable to consent. And this needs to be communicated to them in a completely understandable process. You start to see with the rise of medical misinformation that people are, I mean, by definition, told things which are completely false. You saw this a lot when it came to the vaccine in 2020, but you see this, well, just vaccines in general, but all sorts of different medical practices. And I think there's this really interesting question here, which is if people get their information online, that's the primary way that they get information. And if that information is not curated properly to them to be able to tell them correct things, um, and if that information is constantly leading them to believe false things or things which are we can even think of as egregiously false claims like vaccines commonly cause autism, then it may very well be the case that if someone has been fed misinformation, then they actually lack the ability to give informed consent. And, when we were talking about the child research, one of the things which I talked about was how we have this difference between consent and assent. Consent is essentially the ability to do otherwise while having all the relevant information and not being cognitively impaired in any sort of way. And assent is very much just the ability to do otherwise, or what may have been, or what was called in the past voluntary consent. If you remember in the Declaration of Helsinki, they start to come up with this idea of informed consent. But before that, in the Nuremberg Code, they really just refer to voluntary consent. Um, And now, if we have this idea, this difference between assent and consent, and we say that in situations where people are not able to consent, where they can only consent, we'll oftentimes say in these situations that this then justifies coming up, finding some sort of consenter via proxy for the patient, or this justifies an increase in paternalism, an increase in doctor or government control, then you could maybe make the argument that misinformation, if it leads to the impairment of informed consent, could actually um, justify sort of higher levels of paternalism and maybe the government or medical professionals making decisions for the sake of patients who have been misinformed. It's an interesting argument. It's something that I've been thinking about quite a lot recently. Um, I think that there is some reason to believe this. Um, but I think that sort of general consensus is going to be something like this. Yes, misinformation leads to a lack or an impairment of informed consent, but enforcing that is a slippery slope. We have seen time and time again that medical professionals when given the ability to be very paternalistic, start to make some ethically egregious decisions. Um, for example, you start to see in the past, autonomy really wasn't that much of a value, which was in medical ethics, and this eventually led to, these terrible research studies like the Tuskegee experiments, which just violated civil rights left, right, and center for the supposed sake of the general good, of the greater good. However, for examples like the Tuskegee experiment is actually clear that that didn't lead to the greater good at all. It was just people kind of being fascinated for the sake of science and then doing these absolutely horrendous studies to African American, to poor African American men in the South from, I think that was like 1920 something to like 1973. Um, I think that these slippery slope arguments are, I mean, people sometimes talk about slippery slopes as being a type of fallacy, and slippery slopes certainly can be fallacious. I've given the example before of the classic argument against gay marriage, which is, something like, well, if we let gays marry, then what's next? Letting people marry their cousins and their dogs, then their mother, obviously that's ridiculous and a fallacious slippery slope, but there are slippery slopes which are completely reasonable. Classic example of this is going to be something like, okay, well, if we let Hitler start to rebuild Germany's military, then he may invade Czechoslovakia. Then, if he invades Czechoslovakia, then he may invade Poland. Then he may invade France. And that's what people were saying. People were essentially saying, like, no, come on, that's a ridiculous slippery slope argument. Hitler's going to stop at the second he invades Czechoslovakia, but he's not going to invade Poland. And even if he does invade Poland, he's not going to invade France. And obviously, as we know from history books, that was completely incorrect. Um, Now, there's also, I think, an even greater risk of letting the government be paternalistic. Um, Especially as we've seen in recent years that the government and medical policy is oftentimes motivated by political intentions. If we let the government be paternalistic and we just let them decide what misinformation may count as, well, then we may just see every 4 years, this flip-floppingness between what the government's going to force people to do and stuff like this. So it may very well be the case that misinformation can impair informed consent, and that if policymakers are accurate epistemic sources, or accurate sources of information, then they could justifiably be paternalistic, but it may very well be the case that in actuality, with flawed systems and flawed agencies and flawed agencies which have people that have a history of abusing their power, maybe yes, people lack informed consent in these situations, but the best thing to do is just to essentially act like they do have informed consent. It's an interesting thing to think about nonetheless. But I mean, even assuming that the government could accurately enforce, or sorry, kind of be reliable, make reliable decisions about what is considered medical misinformation or not, you could argue that enforcement of misinformation itself, instead of enforcement of what medical practices people should have done to them. But like enforcement of medical information, misinformation itself, or sorry, sort of the censorship, that in itself would be a direct violation of rights, of First Amendment rights. Um, However, the sort of lack of informed consent, which comes from like the downstream effects of misinformation, that's sort of an indirect violation of rights, and perhaps the direct violation of rights should be prioritized or should be avoided before the indirect prioritization of rights. There are all sorts of different stuff that you can say about this. I want to make two kind of takeaways, and these are like personal takeaways that I have. I don't expect anybody to agree with these. Um, but I think they're personally correct. And again, you can't really talk about medical policy in these contexts without talking about politics. Um, I think that when you think about consent, you can't just think about the ability to decide otherwise. Um, You also have to think about other factors, such as external pressures and accurate information. This seems completely reasonable. Um, I think just put like this, everyone will agree. But I think it's actually really important to note that we don't always think about consent like this. Take, for example, policies regarding cigarette consumption. It's very clear that cigarette addiction adds external pressures onto people to smoke more. It's very clear that probably the majority of smokers, probably the vast majority of smokers in the United States, they actually want to stop smoking, or at least they want to stop smoking eventually. And they may have the ability, in some sense, to do otherwise. However, that ability is greatly harmed by the pressure which comes from nicotine addiction. If we think about this as a factor which eliminates autonomy and then eventually maybe makes consent impossible, then you could very easily make the argument that governmental agencies should actually restrict the purchase of cigarettes or the purchase of nicotine in general. Um, Now, when it comes to accurate information, you oftentimes hear these highly libertarian arguments, which essentially says, well, people need to have the right to be able to say whatever they want. We need to have sort of be free speech absolutists. And it may be the case that it's quite literally impossible to give everybody all of these freedoms. It may be impossible to give them the freedom to make accurate, informed decisions while also giving people the ability to say whatever they want. And it may just be sort of misguided to go ahead and say, well, we need to just give people personal liberties, just let them run wild. Well, it may be the case that these liberties are automatically going to conflict with each other. And if they're automatically going to conflict and we just care about liberty in general, then I think the question is, okay, well, which one should we prioritize? And I think that the most a reasonable response or the most intuitive response maybe would be to think, okay, well, which one's more important? Um, in general, when you have sort of rights-based philosophies, you are going to be able to cook up situations where these rights are necessarily or can conflict with one another. And it's not very helpful to just say, okay, well, rights are important. We can never violate these rights. Um, if you have rights which will eventually conflict with one another. That's my takeaway. Um, I think rights are very complicated things in ethics. Obviously important. I mean, I want governments to believe in human rights. But there are definitely some structural problems that can come about from them. Okay. Let's talk about vaccine mandates. Okay, let's talk about vaccine mandates. I think that vaccine mandates are oftentimes misunderstood. Vaccine mandates are pretty much never quite literally forcing people, like holding them down and injecting them against their will. In general, vaccine mandates are conditional. So there'll be something like, in order to send your kid to school, in order to work in a specific field, whatever it is, then you need to be vaccinated. Um, I think there are two kind of types of vaccine mandates that we can think about. The first one would be governmental vaccine mandates. Um, and the second one would be vaccine mandates by, private entities. In general, we take it that vaccine mandates by private entities are going to be less controversial or less problematic, or less possibly problematic, I should say, than vaccine mandates by governments. To some extent, private entities have rights about who can enter, who can't enter, stuff like this. I mean, this gets incredibly complicated, and I don't know the ins and outs of this. But in general, I think that most people would find vaccine mandates by private organizations or private entities to be less concerning than vaccine mandates by governments. Um, Now, we generally hold, right, in ethics that uh, people have the right to make decisions about their bodies, and people have the right to bodily autonomy. And it may seem that vaccine mandates, even though it's not quite literally forcing someone to do down, it may seem coercive in some sort of sense. So there's sort of an intuitive reason to believe that vaccine mandates may violate people's bodily autonomy, in some cases at least. But we also, in general, are, in terms of sort of the Western tradition where there's a focus on liberalism, we generally try and think about what people are allowed to do as individuals rather than thinking about what would be best for the group. Um, I mean, this like goes into, day one of medical ethics. We were talking about whether or not it would be fine for a doctor to take a healthy patient, then cut him up and, take his organs and then give his organs to five people who need organs in order to live. I mean, is it fine to kill the one person in order to save five other people? And, everybody thinks, any reasonable person thinks that no, that's obviously completely impermissible. You can't let that happen. But I do think that vaccine mandates have some intuitive pull. I personally think that there are plenty of times where vaccine mandates are completely permissible. And I mean, it's also important to note that we can take a look at sort of precedents, like ethical and legal precedents in the Western tradition, and perhaps maybe that needs to be criticized to some extent. So just because we've, in general, held some sort of principles to be true, because, we generally have these sort of liberal political and medical traditions, it doesn't mean that they're necessarily the correct ones, although I think that in a lot of cases, they are, and there's good reason to believe so. But what are the general justifications for vaccine mandates? Um, and this first one, we already talked about this a lot. We can talk about instances of exceptional cases. It may very well be the case that we should, in general, support individual rights and prioritize at least some individual rights over the well-being of groups. However, in some exceptional cases, especially cases where the well-being of great amount of people are dependent on the well-being of the acts are dependent on the decisions of individual people, perhaps we need to sort of flip the scale over to think about the broader group. I think there is a lot of intuitive appeal to these types of cases. So, like taking a look outside of medical ethics, most people believe that it is pretty much always impermissible for the government to torture somebody. But we can think about sort of cases, sort of these perhaps implausible, fanciful cases where someone's about to nuke Manhattan or something like that. You have this individual lone wolf terrorist, and he somehow got his hands on a nuclear weapon, and it's about to go off, and then we somehow get the terrorist, and we're trying to figure out, okay, well, where's the nuke? Where's the nuke? And the only way we can get this information from him is if we torture him. Um, Actually, this is sort of contingent, but evidence shows that actually torture is a very unreliable way to get information. But, we're just thinking about fanciful cases, so it doesn't need to be accurate. I think if this case was actually true, most people would say that it's completely permissible, maybe even required for the government to torture this individual person to save, I don't know, 5 million people or however many people are in Manhattan. Um, and what's happening in this case? Well, the obvious thing that's happening is that we have some sort of exceptional case, and because there's an exceptional case, we should essentially um, prioritize the well-being of a lot of people instead of the well-being of some individual person or the individual liberties of some person. And perhaps this can apply to vaccine mandates as well. I think that this argument has a lot of intuitive appeal. The second argument, right, which I'm somewhat fond of, although I think that there's, as I was saying earlier, sort of concerns regarding slippery slopes and such, is this argument that misinformation stops informed consent. Now, it's certainly true in the real world that when there comes to public health emergencies, when there are public health emergencies, there is a mass amount of misinformation. We were just talking about this a few minutes ago. If we believe, as I was saying, that misinformation may stop informed consent, then you could possibly argue, well, consent's actually impossible in these cases, or at least if people are misinformed. So instead, what we have is just assent. But if we only have assent, then we can allow some level of paternalism. So then maybe it's fine to kind of have these vaccine mandates. The third sort of kind of interesting argument for vaccine mandates, and this was made in the assigned reading. I can't remember who made it. I should have written that down. Oh well. But this argument is essentially that third-party coercion does not necessarily prevent informed consent. And this was essentially the argument. So consent is something that a doctor or a medical practitioner needs to get in order to perform some sort of procedure. If the doctor themselves is not applying the pressure, the coercion, such as the vaccine mandate, um, then the doctor themselves isn't depriving the patient of informed consent. And it may be the case that if the sort of pressure which is created by the mandate, something like, well, in order to continue working your job, you need to get vaccinated. Uh, if that's not completely egregious, then it may very well be the case that the patient has some ability to consent, but because it's not the doctor that is depriving them of part of their ability to consent or part of their autonomy, um, then the doctor's not coercing them. I think that this is kind of a crazy argument, but I think it's really fun, if I'm being completely honest. I think that we it starts to get weird if you could essentially just like set up this network where you can say like, okay, well, it's actually fine to pressure somebody to do this as long as the person pressuring them isn't the person who's doing the procedure. This just seems very weird to me, but I think it's an interesting argument nonetheless. Okay, let's talk about the distribution of resources during a pandemic or during a time of crisis. Okay, so when we're talking about the distribution of resources during crises, what I'm really thinking about is the distribution of like medical resources such as ventilators, masks, vaccines, stuff like this. And actually, the readings which we go into, they partly talk about how the ethical requirements may vary based upon what type of equipment or what type of goods we're thinking about distributing. Perhaps the ethical requirements for distributing vaccines are different from the ethical requirements of distributing ventilators. Um, we're not going to get into that in this lecture, but it's an interesting thing to think about nonetheless. There's sort of two related subtopics here, which I want to talk about. First is going to be like geographic distribution. Um, for example, which hospitals should we send resources to? And how do we determine how many resources we're going to send to different hospitals? That's different from deciding who should get care. I guess we should put this as distribution of resources and care during crises. So to show how this is different, we can think about, pandemic or some sort of crisis happens. We're trying to decide, okay, well, we have X amount of ventilators. How do we decide what to do? And we eventually decide, okay, well, we're going to send 100 to this specific hospital. And then we send those to the hospital. We decide which hospital to send to, but we still have to make the decision. The individual doctors and medical practitioners at that hospital still need to make the decision. Okay, well, we have more people needing ventilators than we have ventilators. So how do we decide who to prioritize? When it comes to both of these, there are kind of two principles which are um, pretty universally agreed upon. The first one is that we should try and benefit the most amount of people. Yet again, this is an example of sort of considering the net benefit or the most amount of utility seems to become critical when we have a time of crisis. And the second principle that people kind of universally agree on for the most part is that we shouldn't prioritize people. We shouldn't make socioeconomic priorities. We shouldn't prioritize poor people over rich people or rich people over poor people. Seems pretty reasonable. Now, I think there are actually some really interesting cases where it seems to be impossible to fully uphold both of these principles at once, especially when it comes to the geographic distribution. So, like one example would be something like this. I saw a talk on this recently, which was incredibly interesting. It's actually a professor over at CU's medical school who who is writing a book on this. So, say that there are two hospitals. One of them is in a poor community and is very ineffective, meaning that um, the level of care that the hospital is able to provide, just, I don't know, based upon you can think about staff competency or maybe training resources or something like that. But for whatever reason, the level of care in this community is, in this hospital is just kind of subpar. And then we have one of them in a rich community that is very effective. Its care is, just through the roof. And let's say that there's a pandemic and it's impacting both communities relatively equally. And we are trying to decide, okay, well, who should we send? How many resources should we send to each hospital? And let's say both communities have the same number of people in them and they have the same number of expected patients that would occur. It may very well be the case that in order to benefit the most amount of people, in order to save the most amount of lives, we should actually prioritize, or if we're just trying to benefit the most amount of people, just trying to save the most amount of lives, we should actually send more equipment to the richer hospital, the hospital in the richer community. However, it seems like doing that would be um, making some sort of socioeconomic priority, at least in effect, or would be causing there to be some level of injustice. And questions like this are incredibly interesting when we have to sort of weigh values like justice and equity against values like utility or just net well-being in general. I don't have an answer to this. There's not a universal answer to this. The person who's writing this book, he actually argues, if I remember correctly, I hope I'm not misrepresenting him, but he actually argues that we should give some priority to the hospital that is more effective, which will be able to provide better care, even if doing so would create more injustice in the world or would result in more injustice. Okay, let's think about distribution of care specifically. I think that this is personally a more interesting question to me um, than geographic distribution of resources. There's sort of three main models that you can do. The first model that you can do to decide who gets care and who doesn't get care is you can come up with some sort of ranking or priority system. You can say, okay, well, the hospital is going to decide, right, who is to some extent more deserving of care. Now, there are, I think, two main ways that this could occur. We can think about ranking need. And I think that this is pretty intuitive. We should perhaps give someone who clearly needs medical care care faster than someone who doesn't need medical care as much. I do think that there are interesting questions which stem from this. Take, for example, a case where there may be someone who is a cancer patient who maybe has some sort of cancer which has a high mortality rate, and that person gets some sort of disease which is being spread by a pandemic. And it's very clear that if they have that disease untreated, then they're going to die. If that's the case, then that person is going to be prioritized if we're just ranking need based upon who's going to get what care. However, it may be the case that they're likely going to die anyways. And the question is okay, well, you have someone who's very unfortunately likely going to die anyways. Is it fair to essentially take those resources away from someone who may very well need that care in the first place? Um, when you have a distribution of resources, right, a limited distribution of resources, and you have these sort of crises, you're sort of forced to make these seemingly impossible decisions. I think it seems very macabre, very inhumane to be like, oh, well, this person's going to die anyways. However, if we're really thinking about equity, it could very well be the case. And look, I'm not making a stance on this either way, but you can see how someone could make an argument that it would actually be the most just to not prioritize someone who's likely going to die anyways, but is definitely going to die if they are left untreated. One time I was actually giving a lecture on this, and a student started crying when I was talking about this. So I don't know. I always get a little nervous when I talk about this, but whatever. The second type of case, or the second type of way that we could distribute medical care is first come, first serve. I think that the primary problem with this is that, oh wait, one second, I realized I skipped something earlier. Okay. So sorry, going back to the priority view, we can essentially say, well, we need to prioritize certain people. We could say that we need to rank care or rank need, and then people who need something more could get care first. There are interesting and difficult questions that come from that. We could also prioritize certain attributes from people. So, or certain, people who meet some certain condition. Um, for example, perhaps it could be the case that people with children should get care first, or that very elderly people shouldn't get care first if we're just trying to think about the number of years which we're going to save. Of course, that would conflict with ranking need oftentimes. One kind of problem with this, which you'll see, is that it seems to really leave open the door to biased viewpoints being prioritized, or sort of people who are seen problematically as more desirable being prioritized. This was in one of the optional course materials, but I had this podcast on what was called the God Committee, and essentially there was some sort of medical intervention which was created, and it was sort of a miracle medical intervention. I believe this was sometime in the early 70s, if I'm correct. And there is some sort of device which could save people. I think it may have actually been an early ventilator. I may be wrong about that. But they only had a certain number of these devices. And they had a number of people who were applying to be put on this device so that they could live. And then the doctors essentially had to make decisions based upon, okay, well, who's going to get care and who's not going to get care. And what they ended up doing is they actually ended up sort of having this external committee, which was just regular people, really, review these applications and then decide who's going to get care and who's going to die. And what you end up seeing is that there was definitely some sort of priority for people who would be considered problematically more desirable, whether it be richer people or white people or people who seemed less, I don't know, more, you had like traditional values and a traditional family. And obviously, we want to avoid stuff like this from happening. But maybe there are some qualities which we should prioritize. Like maybe if someone's dependent on someone else, they should get some sort of care because that's going to result in the most net benefit if we save their lives versus somebody else's life. But this is a difficult question nonetheless. Okay. Other types of way which we can think about giving priority. We can come on a first come, first serve basis. We can do it on a first come, first serve basis. Um, I think that I mean, it has a problem in that it's going to result in just like completely random people getting care. And yes, it may be the case that there are ethical concerns which come from prioritizing certain people, but I also think that there are ethical concerns if we don't prioritize people at all. Um, there's also going to be some level of inequity which comes here, and one of the readings goes over this. Um, in that it could very well be the case that richer people, or was the case during the COVID pandemic, that richer people had more resources to get to hospitals faster. Specifically, they talk about chartering ambulances because they can afford to pay for private ambulances more. They're able to get to hospitals in further away places and hospitals faster and stuff like this. So this could result in inequity. The third type of way that we can prioritize care is we can just make it random. Now, I think that this is going to have really the same problem that we see, the first problem that we see with the first come, first serve basis approach, which is that this is going to result in a range of people getting care, which seems to be ethically problematic in some sort of sense. Now, one of the readings which I assigned, it talked about appeals processes, which I think is a really interesting discussion. It talks about, it specifically talks about ventilators in an influenza pandemic, which this essay was actually written prior to COVID-19 and this exact problem. I mean, it's not influenza, but it's very similar, need ventilators in the same way. This very problem occurred during COVID-19. Um, and essentially, the question is, okay, well, should we allow people to appeal being rejected for getting a ventilator? And sort of the pro of saying, okay, we should reject this, or the pro of appeals would be generally concerns about equity and fairness. When people are making life and death decisions, especially when there's kind of it's made fast, it seems like people could make mistakes, and if people make mistakes, then we want some ability to catch them. The downside of this is that the appeals process would lead to some amount of deaths because it would slow down processes and say someone is denied a ventilator and then they appeal uh, and suddenly they're allowed a ventilator. Well, where are they getting the ventilator? They literally have to unplug someone and then plug this guy in, and this may result in both people dying. Um, so there are some very interesting ethical concerns regarding appeals processes. But I mean, I think the important thing about this is we can't just think about the distribution of resources. We need to think about all of these different policies, which have quite severe ethical implications. Okay, I think I'm going to end it here. Let me zoom out so you guys can see all of my notes. Okay, well, thank you guys. Appreciate such a great class. Good luck with your finals and everything.